right? Okay. We are in Jimmo versus Sebelius. Did I say that correctly?
Yeah.
Okay. Its impact on health services for the chronically ill. Just want to make sure everybody's in the right place. And this is Jean Macdonald. Jean is the Director of Home Health Policy for the Indiana Association for Home and Hospice Care. She graduated from the Ohio State University College of Nursing in 1964.
It does say on my diploma, the.
I had to read that closely. And her primary focus has been in home care since 1986. Please welcome Jean Macdonald.
There's some seats up here and there's handouts. I do have my master's in management from Indiana Wesleyan. So I've been with the association since 95, but I've been in home health since 86. And as you all know, we've had lots of changes. For those people who are case managers, how many are case managers? How many are providers of home health? Good for you, because you need to know this. You run a Medicare agency? Do you have a Medicare agency?
Yes.
Okay. Because this is a radical change for home health. And it won't be a horrible change, but it's going to be a confusing change for all of us. Okay, so she looks at the lost look on her face. Yeah.
No, I'm just listening to you.
Oh, okay. And I thought, oh, okay. Sebelius is the former head of CMS that got herself in so much trouble over the accountable care. Remember, she was the one always there in front of all the hearings? That's Sebelius. So, let's see, I have, no. There, okay. The lawsuit alleged that CMS was requiring standards that weren't really there. They were prohibiting services based on standards that were not in the Medicare law, the Social Security Act. Okay. And because of that, they were denying chronic disease care in home health. And you all know that. Remember, home health agencies had to discharge because the patients weren't improving. Okay. So that's what it was. Okay. And that they were using an improvement standard. That the beneficiary lacked the ability to be better. They were going to be chronic, they weren't going to change, and we couldn't care for them anymore. Okay. You admitted them, you discharged. Okay. And even though the beneficiary did require, and I want you to remember the word skilled care. That's what you have to put in your head. Okay. Especially you case managers who work with waiver. Okay. For example, the ALS patient, what do? They don't get better, do they? Okay. They deteriorate. Or the congestive heart failure patient. They've been in the hospital, we admit them, they stabilize, we got them on the right beds, they're taking their weight, we're calling, everything's fine, and we discharge them. And guess what happens? They go back to the hospital. But remember, they were stable, so we had to discharge them. The defendants were HHS. And the plaintiffs were 6 beneficiaries, and then this lovely group of interested parties, Parkinson's, et cetera, et cetera. And they sued Sebelius. Now, the suit is named for Glenda Jimmo. That's why it's the name Jimmo. There's seats up front and there's handouts up front. She's an elderly lady who lost a leg, most of her toes. She has diabetes, blind since 19, and confined to a wheelchair. But because she wasn't going to get better, she was denied Medicare home health coverage. She was repeatedly denied because she didn't meet the criteria. And they said, whoever they are, that she didn't meet the improvement standard. Because what we were doing would not improve her condition. Okay. She and the rest of the group filed the lawsuit. You can see the date. And I remember when it was settled. We were all at our National Association meeting in October, and the buzz went through 5,000 people faster than a bee. I mean, they settled, they settled, they settled. Okay? What does it mean that they settled? Because as a representative who represents home health agencies, my first concern was, are we always going to have to take care of these chronic people for what we're paid? Because you just thought it was opening up Pandora's box and you got to take care of them. Well, it's taken at least a year and a half to kind of figure out we still have some ways to go. Okay. What Jimmo settlement means. It means that Medicare denials based on improvement standard are inappropriate. And it not just covers home health, it covers SNFs. You know that little old man that goes, he has Parkinson's and he goes into the SNF after hospitalization, and he's not going to get any better, is he? Okay. But could he use some more time in there, some OT to learn how to dress himself more? But he didn't meet the standard because he's not going to improve. So the SNF had to discharge him because Medicare wasn't going to pay. It goes for outpatient therapy and home health. So it's not just home health. Because the individual was stable or chronic, no expectation of improvement in a here's a word, reasonable period of time. We never knew what a reasonable period of time was. It depended on what edit was on the computer at Palmetto gave us what was reasonable. And services can be skilled and covered now, even if the patient plateaus, and they can be covered for maintenance only. So those are the changes. Okay. Just as a review, so you know what Medicare home health, what the requirements are. And the first thing is, clients for home health have to meet this before we go any farther. They have to be confined to the home. And confined to the home means it's difficult and taxing for them to go out of the house. They need assistance, and they go out infrequently. They can go to church. They might go to the barber. And I always give the example, I got a call from one of our members, and they were having an argument with the family because Dad was homebound. Dad truly was homebound. But there were 7 kids in the family, and they took Dad out to dinner every night, one of the kids. He got homebound. If they can get him to the restaurant, they can get him to the doctor. Okay? You have to be under the care of a physician, and you have to be under a plan of care that's established and periodically reviewed. Now, remember what the word was? You had to watch skilled, need of skilled nursing care or PT or speech, and a need for ongoing OT. The reason that's in there is occupational therapy is not a qualifying skill for home health. It's the stupidest thing because 90% of the elderly need OT, not PT. They need to learn how to adapt, but that's the OT Association. They got to work on that. Okay. So you got to meet all that criteria before we even look at you. Okay. And it has to be part-time or intermittent. And this is, I think, is going to be our biggest, what is part-time? Because I've talked to our National Association, and he says, the lawyer says, extended hours is not part-time. And I say, but Bill, it says 7 hours a day. He says, that's not considered intermittent. I think where he's coming from, intermittent would be an aide to be here for a couple hours, and then you might have an aide for another, but it isn't continuous. Does that make sense? And it's fewer than 28 hours a week. You can go to 35, but very few of our clients, and most of these are going to be duals. For those of you who don't know what a dual is, it means they have Medicare and Medicaid. Okay. And a patient must meet the criteria specified in the section, okay, to be eligible for payment. Okay, these are the things that came from CMS. And I always want to go, that's what I do. Okay, Medicare statute, what CMS said was, we didn't do anything wrong. The Medicare statute never supported the imposition of improvement standard. They never did. Well, who in the heck was doing it then? Because home health agencies were getting denied right and left. No improvement seen, no improvement seen, okay? In determining, okay, real truth, they denied it all the time. And I will tell you, home health agencies could be paying back thousands of dollars because the patient didn't meet the improvement standard. And it wasn't fair to clients either. And it wasn't fair to the patient who worked so hard to improve and was never going to improve. Okay. Here's what they said again. The beneficiary's lack of restorative potential cannot in itself serve as the basis. Bull, that's what you were doing. Every time a case did not show progress, because we had to chart in detail. They could now walk 10 feet. I mean, if you didn't have it in there and show progress, no progress seen, discharge. Okay. Now, this one is the truth. They did state this. You've got coverage in this context would not be available in a situation where the care needs can be met safely, use of non-skilled personnel. So, home health aid only needs doesn't get you Medicare, and I know most of you know that. Okay. That's why we need waiver and choice or private pay. Okay. Only patients needing skilled services can receive the benefit. Okay. And it's important to know that this settlement is not going to expand the benefit to include aid-only services. So, you know, we can't get our hopes up that we're saving state money. Okay, thus, this is what they say to make themselves feel good. Okay. Such coverage depends not on the beneficiary's restorative potential, but on whether, what's the word? Skilled care is required along with the underlying reasonableness and necessity of services themselves. And when we go farther, you're going to see all the documentation that has to be proven to prove that. Okay? It is a major sea change. And how we're going to be using this, I think you're going to have to give most home health agencies a year to kind of, a lot of them haven't even paid attention. I've been trying to educate members, but not everybody listens. Okay. They never accepted blame. So they said, any actions undertaken in connection with this settlement do not resemble an expansion, but clarify. Well, if they hadn't told every one of the physical intermediaries, we at one time had 5. Did they all sit together in a room and say, we're going to deny improvement? No, it had to come from someplace else. But they weren't at fault. You know, the government's never at fault. Okay. So, CMS had to, in the part of the settlement, they had to clarify all the policies, and they have done that. There is a new policy manual, and if you all are kind of nerdy people and like to know the very details, if you go to cms.gov, Internet-only manuals, it's 100-02, Chapter 7, and you can read all the changes because it's all in red. That's the Medicare payment manual. For you case managers, it doesn't hurt to know that, because then you can intelligently discuss it with the home health agency. Does that make sense? Okay. They have to do an educational campaign. I have yet to see the educational campaign. I just saw the manual come out. I think maybe we had one Med-Learn Matters. Okay. And they have to go back and review claims that were denied. We have yet to see any reversed. But they're so busy denying everything else. So yeah.
How far back will they review?
They were supposed to go back before the lawsuit. You know, just before the lawsuit. That's a good question. I had to think because I remember reading that. Okay. So what services are covered? And home health agencies know this, but I have to review it for the rest of you. Part-time and intermittent for skilled nursing or therapies. Part-time or intermittent home health aid, physical therapy, speech, occupational and medical social service, aid services, and medical supplies. When a patient's on a Medicare episode of care, home health has to pay all their medical supplies. So if they had a colostomy done 10 years ago, and we're treating them for congestive heart failure, we have to get their colostomy supplies. And you case managers will get the complaint because the agency doesn't carry the exact kind they've had for 10 years. We don't have to. We have to carry an equivalent kind. The choice they made was the home health agency. And it's in that manual I told you about. Okay. Services at hospitals, skilled nursing, or rehab when involved. What this means is if we have a patient, especially in therapies, that they're homebound, but they need a whirlpool. Or they're homebound, but they're getting aspiration pneumonia, so we need to get a swallow test. That all is under their episode of care, and there has to be an agreement between the home health agency and that other provider. If they go ahead and the other provider does it, the home health agency doesn't have to pay for it. Okay. So here's the changes in the manual. Now, they're not in red because I think red's hard to read, but it's italicized, so that means the changes. Okay. Again, it is not the presence or absence of the potential for improvement. It is the patient's need for skilled care. And that is going to be the hardest thing for especially case managers to try to explain to patients. Myrtle, you do not have a need for skilled care. You need assistance in activities of daily living. Well, I got a heart condition. Yes, but that, you haven't been in the hospital in a year for your heart condition. You just need somebody to get you in and out of the shower and clean your bathroom. If all eligible coverage requirements under home health benefit or med skilled services are covered when the individual assessment of the patient's clinical condition demonstrates that the specialized judgment, knowledge, and skills can prove it's necessary. So that's how they've kind of defined it. It's skilled assessment, skilled services. We're going to go over a couple of examples. Okay. And, again, these are to maintain the patient's current condition. Remember, before, they didn't care about to maintain anything. They got you better and dropped you and got you sick and dropped you. Okay. And to prevent or slow deterioration. The MS patient. If we keep PT in there, maybe even once a week, and check to make sure the PT patient's doing their exercises or their aides assisting them in their exercises. Okay. But if the individualized assessment doesn't show the need for skilled care, and here's where it's going to be really hard for home health agencies, because they're really going to have to, the nurses are going to have to really document it. One of the biggest trouble home health has, our nurses don't like to document well. Okay. And now, if you don't document exactly right, you're not going to get that skilled coverage. It's going to be a learning curve for providers. Okay. Patient's special medical complication requires a skilled nurse, even though it may not be skilled, but because of the patient's condition, we could do skilled. And that's where we're going to have that. Oh, how do I document that? Okay. Needed services are complex. See how they're trying to get the home health agency, because if they don't fulfill all this, they're going to be denied. Okay. Must be inherently complex, safely and effectively performed only by or under the supervision. Meaning, maybe it's something, maybe the aide could do it, but this person has a history of pressure ulcers, and if she's not getting the best of care, isn't eating properly, the family situation doesn't change her enough, et cetera, maybe we do need the skilled nurse in there so she's not going back into the hospital because of another pressure ulcer. But we're going to have to document that in detail. Why? Even though all she needs is an aide to bathe her, keep her clean and dry, make sure she's turned, make sure the family turns her. We may need that nurse because that's complicated. Okay. If it can be performed by an unskilled person without the supervision, it's not going to be covered. Now, the unavailability of a competent person to provide non-skilled services does not make it skilled. The son doesn't want to take care of his mom. We all know that, and that's okay. I always say, my husband did all my mother-in-law's wash, but I did all the personal care. We divided. And he even did her wash when she went to the nursing home. I was so proud of him. Okay. A service by its nature requires skilled nurse to provide, and in fact continues to be skilled even if it's taught. So we can teach a family member to do a dressing change, but that's still a skill. And we may, with documentation, be able to continue to see that patient, because maybe we need to go out once a week to assess it, to make sure the family's doing it right. And depending on unique condition, continuing to be necessary for patients whose condition is stable. Okay. Now, here's what the Home Health Agency is going to have to document at every visit. Or they're going to get denied. Because I can just see in a year we're going to get requests for additional records. We're going to get these ADRs pulling that, and it's going to be denied, does not meet skilled criteria. So, every record's going to have the history and physical exam pertinent to that visit. So we're going to have to, most of the time you go out and do a visit and you don't do a complete physical. I mean, that's going to take you 20 minutes and you don't have that time. But you're going to have to adapt something so you get that done, okay? And you're going to have to write the responses or changes in behavior. You're going to have to do the patient and caregiver's response. The man yelled at me because he hurt when I moved him. And we've got to have to document what our plan is for the next visit. Well, we've always been doing that. You usually plan out what you're going to do. But it's the other stuff that's going to be in much more detail than we have before, if you're going to use this criteria. Okay. Detailed rationale that explains the need. This is each visit. Complexity of the service. Why does a nurse need to be out there? Okay. Pertinent characteristics of the beneficiary or the home. Home's a good thing to document. Called the area agency on aging, got the home bed bugs out of the home. Well, don't you guys do that for us? Boy, Fort Wayne's had a horrible bed bug problem this year. I swear. Glad you didn't. Okay. Adequate description of reaction. Patient laid there and smiled. No. Okay. And a clear picture as well as next steps. And I think agencies are going to have to really sit down and really look at this. And I think that they should take a couple or three of these people they think they could keep going with, that maybe would get Medicaid, but they probably still meet Medicare criteria, so we may have to combine. We have to have objective measurements. Now, objective measurements for therapies are not hard. They have all these tests that they can do. But we've got to prove changed behaviors. Some of our patients' behaviors will never change, right? They never change. Here's some examples. Patient has a plaster cast, okay? Patient pre-existing peripheral disease. Plaster casts are no big deal, but because this patient has a plaster cast, that's a skill. We've got to determine, besides teaching, pain control, skin care, we may have to go back in there because plaster casts can cause pressure that people won't even be aware of. They aren't aware that toe's turning black. So that would be a reason we're there a lot. We've done all the teaching, right? We've got them, their pain's under control. We've taught them their medications, taught them complications. We've taught skin care. Should we still be in there? Well, if we're going to look at it's a skilled service, yes. In the past, we've probably done all that. told them to see their doctor. Okay. Patient has irritable bowel, recovering from rectal surgery. Can aid give an enema? Sure can. But in this case, because of the surgery, that's now a skilled service. You still could put an aid in there for personal care, but the aid's not going to do the enema. Physician has ordered skilled nursing for self-administration. Okay. But are you all aware that if there is, patient cannot give their own insulin, Medicare covers it? If we try to find somebody to do it, we try to teach somebody. But if you have a patient who cannot give their own insulin, Medicare will cover it. You're going to have a very difficult time finding a home health agency that can do it, because if they're getting it 4 times a day, they may not have staff to cover that. Patient with advanced MS, okay? Yes, you're going to have that covered. Even though they have MS, they have an exacerbation, we still may even be able to keep OT in there and PT to make sure they're doing their maintenance program, to keep them in optimum condition. This is a really good one, I think, because most of you, we think about moving patients to hospice, but that doesn't always happen. There are patients who don't want hospice. They don't want hospice because they don't want to lose their extended hours Medicaid. Well, Medicare can provide all those things under Medicare and then combine it with Medicaid and get pretty good coverage. The agencies just have to know how to play nice in the sandbox and share cases. And if you ever have providers that are having problems with that, you call me and I give them the shovels and show them how to do it. I'm working on one right now. Okay. Example, frail man hospitalized with pneumonia. Doesn't eat. Patient's discharged for monitoring fluid and nutrition intake and assessment of need for feeding tube. Observation, monitoring, skilled nurse of patient's oral intake. Yes, that would be covered. And it could be covered longer than just an initial if that patient had skin breakdown, lived alone. Remember when they said home situation? Lived alone, didn't cook well anymore. Daughter brought over TV dinners. She's kind. Okay. It's better to do meals on wheels because they can give you no sodium. Okay. Chronic non-healing skin ulcer. Diabetes, spinal muscular, past patient's wound have deteriorated, requiring patient to be hospitalized. Previous skilled nurse has trained patient's wife. Treating physician orders a new episode of skilled care at a frequency of 1 visit every 2 weeks to perform. Perfect. This is a perfect example of how to use the benefit. The wife's doing it. But the patient has a history of breakdown. In the past, once we trained the wife, bye, call me if you need me. Now, you can keep, you're not going to send a nurse 3 days a week because the wife knows how to do it. But sending a nurse every 2 weeks to assess, to answer questions, nutritional intake, isn't that a skill that you need if you have skin breakdown? So see, nurses are going to have to go back and look at all those wonderful skills we learned in training. I've been out 50 years and 2 months. from nursing training, and I even remember nutrition has to do with wound healing. Now, therapy services are exactly, I didn't write everything down because we've already done that for nursing, right? It's exactly the same thing. If a patient covered skill therapy requires skill, okay? They have to document the need for skill. And by the way, maintenance programs cannot be done by a therapy assistant. Maintenance therapy can only be done because it requires the skill of a therapist. That's why some services cannot be done by an aide, because they require the skill, okay? Okay, mandates are the same. Okay, I want everybody to stand up. Turn around. Turn around. Turn around again. Okay, now you can sit down. The two that were asleep are awake. It's hard. Wasn't that cake wonderful? I mean, luckily I don't like chocolate, so I ate part of the lemon cake. I know, I'm weird. I do not like chocolate. Okay. Here's an example. Patient received gait training, has reached maximum restorative potential. Physical therapist is teaching patient family. Visits by the PT to demonstrate and teach activities which by themselves do not require skills of a therapist would be covered since they are need to establish the program. Patient's maxed out, okay, but she's going, or he's going back for a few weeks to make sure that maintenance program is being continued. Okay. And there, can't be done by a therapy assistant. Okay. Patient's medical complication, this isn't an example, this is a statement. I realize today I should have crossed the word example out. Particular patient's special medical complications, remember? Medical complications, medical complexity. All those words are basically the same. Parkinson's patient, this is the perfect, I love that. A Parkinson's patient, you go out and you do some exercises and they still stop, right? You still have to say right, left to walk. You teach the family all that. But if we put and continued with, remember, skills, OT, to make sure that that patient maintains their ability to do self-care, we probably can keep therapy in there. Now, again, it's not going to be every three times a week, because that's acute treatment. Yeah?
You said OT.
OT is not a qualifying starting skill. Once we get into a case, OT can be by itself. Yeah. Okay. What new problems are going to appear? Number, well, we got 20 minutes, so. What time is this now? Yeah. Okay, yeah. Good, okay. Well, we're going to have, we feel, major increase in additional documentation required. And what happens to home health agencies, they look on there, they go on the computer system, and it'll notify them that an ADR is coming. And they have to send the entire blasted chart. And they could get denied. And if you get too many of those, they'll stop their payment until they get them corrected. And that's why I say, till you really get good at taking care of these patients, I wouldn't do a whole lot of them. You want to make sure you're doing it right. Okay. That you're going to get denials for incomplete documentation. And let me tell you, they will get denials, so have case managers have some patience with them, okay? And they're going to get concerned because the physician's documentation isn't detailed enough. Why do you need maintenance therapy? Well, the doctor's got that doctor cannot write maintenance therapy. The doctor has to send a letter for you that proves why that patient needs maintenance. We can barely get them to do a face-to-face, let alone this. Okay. Medicare recipient not understand skilled care. And this is a real concern I have, is the fact that the Medicare recipients are going to think, oh, Jimmo versus Sebelius. It opens up the world for me. Well, that's why I said I do this class, because case managers want to always open up the world for clients. Well, it only opened that far. Okay? So don't think we're not going to use waiver and choice anymore. Because you need to talk it over with the home health agency so they can really sit down and figure out, can we get this covered? Is this a complex enough case to keep that in there, to keep skilled in there? I always give the example of the congestive heart failure patient. Our congestive heart failure patient, they go to the hospital, they dry them out, they send them home, we admit them, we teach them how to take their medications, we teach them how to get on the scales, we teach them how to call us with their weight, we teach them not to eat, condensed soup and TV dinners, and they're not short of breath, they feel wonderful, and we discharge them. Then they're back in the hospital, and we do the same thing. But if we can keep a skilled nurse in there once a week going out and monitoring Charlie, couldn't we save that Medicare system that hospital bill just with one visit a week? And maybe the nurse calls another day, or even better, telehealth. Except Medicare doesn't pay for telehealth. By the way, Medicaid is going to start paying for telehealth. We got that law passed a year ago, and they're working on the pricing now. Again, documentation. Every visit has to have this. And I think some of you case managers will be able to help, because you probably know the family situations better than home health agencies do. Because you have that daughter calling all the time, bugging you. Right? Yeah.
So if you've got somebody that was used to congestive heart failure, for example, and they are stable, so usually what's a typical length of time that Medicare would allow, like a weekly nursing visit for somebody who's been stable?
If you've got a history of repeated hospitalization, then it should cover it, because you're preventing rehospitalization. Let's say they've been in 3 times in 6 months. Can we keep them out for 6 months? I bet we can. Does that make sense? So it may be another 6 months, maybe it's a year, and we can prove that they're stable, there's a family member working with them, stuff like that. Now, it's going to be a trial and error at first.
Yeah, because I still even hear, well, they're stable, so we can certify them for another 4 weeks or 6 weeks, and then
Yeah.
And then usually I do have a couple people that they, within 2 weeks of
They're back.
they're back in. I get a call that they're back in the hospital
Yeah.
again.
And those are the people we want to stop going back in the hospital. So you need to work with your home health agency, and if they're IAC members, please tell them to call Jean. If they're not, tell them to call Jean. And I will say, I'll talk to you for initial membership due up now. I usually answer one question for non-members. And before I forget, I want to tell you the law that changed this year, so Patricia, don't let me forget. Okay, so all these things are going to have to be in the documentation. Okay, how would this decision interface with Medicaid covered services? We're not sure. Okay. But we know aid services for extended hours won't be changed. If they only need aid and they're dual eligible, we're still going to be using our extended hours Medicaid. Okay. Ventilator patients, G-tube feeding, terminal illness, severe pain control. We'll probably do a little bit of both. You know, now when we have dual eligibles and they go into the hospital and they come out eligible for Medicare, Medicare is always primary. And Medicare agencies must provide the personal care that that patient needs to improve their condition or prevent deterioration. And you can tell them I said that. Because what they'll say is, well, I've got choice hours, we'll let choice pay for it. No. We as Medicare providers must provide their personal care. And it doesn't mean BASS. There's no such definition in the Medicare criteria that says BASS aid. There's other things besides giving a bath that an aid should provide. Okay? And we're not sure on the ventilator patient. I think that's going to be what Bill said. It's not intermittent care because they're all day. Now, I don't know what happens if that patient gets a pressure ulcer. We don't know yet. Okay? Again, it's a learning process for all providers. Remember the definition of intermittent. Okay, are you confused?
Don't forget to.
I won't. Yeah.
We have some Medicare agencies that just don't even have home health aides on staff at all, but yet they accept cases for PT, OT, skilled nursing. What should we do in those situations? I mean, I've had conversations with them and said, if you don't have a home health aide and that individual needs that, you should not accept the case and we should look for another agency.
And if you can only accept those patients that you have the ability to care for their needs. If they need an aid and they're not accepting it, there's a place called the State Department of Health. Because that's not fulfilling what they're needing. And I know but no, you've got to do it. We don't have any choice. And I know there's people who go, well, you go ahead and do the Medicaid hours. We'll do that. No. That's, the Medicare agency will only get in trouble under the conditions of participation. But this Medicaid agency over here, they're going to have all their money taken back because that's a dual eligible Medicare should pay. And they're up a creek without a paddle. I'm sorry, they have to do it.
That's where I think
And
we
you
still
can
have
call
a lot
me.
of confusion is when Medicare's in there, can Medicaid PA ever be in the home
Yes.
at the same time?
Yeah.
That's where we get confused, I think, even as case managers.
Yeah, I actually have that presentation on my laptop here, but we don't
And
have
I
time
think
to do
the
it.
home health agencies don't understand that either.
Well, I
because
have-
I get calls asking me,
I have
okay,
taught
can I?
it and taught it and taught it and taught it. What I will do, I will see if we can put together a webinar, and then you guys can just dial in. I have been to almost all the AAAs. I haven't been down here for a while, but I've done the presentation a lot of them, and I'm happy. We'll just do a webinar.
Yeah, because we have a lot of new case managers. The
Yeah.
last time that you came down,
Yeah.
We've probably gotten 12
Yeah.
new case managers since then.
Yeah.
So when you say you're specifically referring to Medicare, home health, and PA, you're not, I mean, when you say
If
that
Medicare, if the patient has waiver, the only waiver they really should have is respite and home health.
right, but when you said talking about putting together a
You
webinar,
can-
you're saying
No, it's called Medicare, Medicaid waiver, how you can and cannot combine them.
I was referring to her specific.
Yeah, that's
question about
that's the teaching.
PA and.
Home health. And that's what
I'm sorry.
that's what my
Sorry, I was
presentation's on. Yeah. What I wanted to tell you all, last year we got telehealth passed through the state legislature. This year, if you know under assistance with medications from both the home health aide and the personal care attendant, it always says you cannot assist with any controlled substances. Well, now, as long as the medication is preset, an aide or an attendant can assist with any medication. So if the daughter puts the Vicodin in those little pill things, the attendant can give the Vicodin. And we push that because I don't know if any of you are old, but there are times when I hurt. And we were denying our patients their pain medication. And we didn't have any trouble. It just, I thought we had problems with Senator Miller, and no, went right through. Fine, change it from non-controlled to controlled. So if you go into the law, it now says non-controlled and controlled substances. And it's both for home health aides and for attendants. Any other questions? Yeah.
That means the medicine has to be set up. I mean, they
Yes.
can't just take them the bottles.
No. The only time they could take the bottle is if Patricia looked at me and said, would you go get me my Vicodin bottle? And I go get it and give it to her because she's going to take it. I'm not going to open it and put it in there. A quad could say, because they're bright and intelligent, most of our patients are cognitively impaired, most of them. But a quad could say, Patricia, would you go get me my Vicodin? And I need you to open the bottle, Patricia. And I need you to put it in my mouth. Give me some water, because he's directing his care. Does that make sense?
So that is allowable?
Uh-huh.
What if that person has every 10 minutes bring you a bike, they're overdosing or whatever.
Well, but
I mean, do they-
you have your attendant has to be trained and competent to know that if they're there for 4 hours, they don't get 4 Vicodin in 4 hours. Yeah.
they need
And
to
I always
follow
tell the providers, PSAs and home health, don't have that Vicodin sitting out. Have the family put it away. Any other questions? I will, my information's on the back, so if you need to get a hold of me. I only work Tuesday, Wednesdays, and Thursdays because I'm semi-retired. So I'll be there tomorrow because I got to catch up on it. But my information's there. No questions? I think it's time. Okay?
Thank you.
Thank you. Thank you.